Okay, so think of these two systems of platelets and coagulation as cooperative. They're, they're, they're trying to reach the same purpose. They're trying to stop the bleeding at an injured vessel, right? So, okay, now how can we inhibit the system in patients that are clotting too much, such as in someone with a heart attack, someone with a DVT? Well, antiplatelets. We can make the platelets less sticky and they don't adhere to each other, and we can stop the platelet plug from forming. And that's drugs like aspirin, NSAIDs, and another one in the middle there called clopidogrel, and the brand name is Plavix. Okay, they're all antiplatelets. Okay, let's look at the anticoagulants now. Well, we just spoke about those. Those are all the ones that can alter or inhibit different parts of the coagulation system, and that's the heparins, the low molecular weight heparins, which are injectable, warfarin, and there's others as well. Okay, we're affecting the coagulation system to, and stopping it from forming a fibrin clot. Fibrinolytics or thrombolytics are the identical same name. Okay, it's the same meaning. If you see thrombolytic or fibrinolytic, it's the same term. So these are drugs that activate plasminogen to turn into plasmin. And what does plasmin do? Breaks down the fibrin clot. So these drugs are only used for absolute emergencies, like a heart attack, an acute heart attack, or an acute stroke. We can use fibrinolytics. And typically, in a stroke, we try to use them as quickly as possible, okay? Because we know that as time goes on, the brain is dying when you have a blocked artery. The same goes for a heart attack. So we try to use them as quickly as possible. And typically for a stroke, we're trying to get the drug in. I think it's been extended out to 4.5 hours now. It used to be 3 hours. They've extended the time frame of getting TPA in to 4.5 hours. In a heart attack, we try to get the fibrinolytic or thrombolytic in as fast as possible to break up that fibrin clot. Okay. Okay, so hopefully we can go through this part pretty fast because we've spoken about the coagulation system a bit. I don't think the expectation is for you to know all the numbers of the coagulation system. It's not possible in a short period of time. But understand the idea of the coagulation system is to get to the common pathway, whether it's through the intrinsic system or the extrinsic system, because of a damaged vessel, and to form that fibrin clot. Okay? When we're talking about anticoagulants, we want to inhibit a part of the coagulation system. And we can use heparins. And if you refer to the above slide, you'll see where heparin inhibits it. We can use warfarin, which is oral. Okay? So heparin is typically an intravenous drug in the hospital. But now we have low molecular weight heparins that are given subcutaneously, typically in the abdominal wall. And they work very similarly to heparin. Warfarin, it reduces the production of vitamin K dependent clotting factors in the liver, right? 2, 7, 9, and 10. Okay, so by doing this, they're just slowing down whichever anticoagulant we're talking about. It's just slowing down the ability to form that fibrin clot. And some of these drugs need monitoring while we're giving them. For example, heparin needs monitoring. Warfarin needs monitoring to make sure that we're not thinning the blood too much. Low molecular weight heparins don't need monitoring because they're weight-based. So we give a predictable dose based on the weight of the patient. Okay. Okay, so we've spoken about platelets and their function. We've spoken about antiplatelets such as aspirin or NSAIDs. We've spoken about the coagulation system a bit and some drugs that can inhibit the coagulation system. Let's look at some tests that we can perform on a patient to see how well their platelets are doing or their coagulation system is doing. And also we can use some of these tests for monitoring patients while they're on anticoagulants. So a bleeding time is really the time it takes for someone to stop bleeding after they've been nicked. Okay, so we just nick the skin, and it's the time it takes to form a platelet plug, and it's usually around 2 to 8 minutes to stop bleeding. So that's called a bleeding time. It tests platelet function only. Okay, let's look at some tests for coagulation. Okay, the coagulation cascade leading to a fibrin clot. Well, we use PTT and we use PT. And in actual fact, we're going to talk about another one called INR, which we use much more than PT. So PTT is partial thromboplastin time. PT is prothrombin time. What does PTT measure? Well, it measures the clotting of the intrinsic pathway. So we typically use this for patients that are on heparin. Okay. Remember, the intrinsic pathway is the one where, okay, the body's detecting some kind of endothelial injury and it's activated the intrinsic pathway. Okay. Heparin has a significant effect on blocking the intrinsic pathway, so we use it to monitor how thin we're making someone's blood while they're on intravenous heparin. A normal PTT in someone who's not on heparin is about 25 to 35 seconds. When someone's on heparin and we want to thin their blood, we typically like it between 1.5 and 2.5 times normal. So before starting heparin, we could get a PTT, see what it is, and see where it is between 25 and 35. And then typically while on heparin, we like it between around 60 to 100. So if someone has a PTT of 120 while on heparin, we need to do something. We need to stop the heparin and reset it at a lower rate. Don't give them as much heparin, right? So we monitor heparin and how it's affecting the coagulation system with a PTT. Okay, what about PT? Well, PT measures the extrinsic pathway, and usually your PT value, if you're not on warfarin, is about, say, 11 to 16 seconds. And we like it about 1.5 to 2 times normal. So we can estimate how someone's PT should be while they're on warfarin. Now, the PT became a bit irrelevant after a while because it was replaced by a drug called INR, International Normalized Ratio. Why did we do this? Well, because PTs all over the country were different. So a PT in Florida didn't have the same meaning as a PT in Utah. And so we couldn't use them as comparisons. The labs were just different. So they came up with an international normalized ratio that can be used anywhere in the world. So an INR in Canada would mean the same as an INR in the United States or an INR in Europe. So it's still testing for the same system. We use it for patients that are on warfarin. And a normal INR is 1. So if you're not on warfarin, your INR should be 1 or around 1. If you're on warfarin, we'd like to see it between 2 to 3 normally. Okay? So for example, if you have a DVT and you're on warfarin, we'd like to see it between 2 to 3. and we test it. Okay, we can do a simple INR blood test or even a finger stick test to get the INR, and it gives us a result very quickly, and then we can adjust the warfarin based on the INR, because we don't want patients having very elevated INRs. It's going to lead to much higher risk of bleeding internally or externally. Okay, so this is just a primer on PTT, a bit on PT, and how it's basically been replaced by INR. Okay, and the reason we have these tests is to monitor heparin, or in the case of an INR, to monitor warfarin. Okay, so when we're using INR, and you'll see that PT is associated with it because we used to use PT for this reason, we're using it to monitor warfarin, right? So patients that are on warfarin are getting regular checks of INR to see that their blood isn't getting too thin, or too thick for that matter, because we want them between 2 and 3 usually as a blood thinner. We can use INR for someone who we think is deficient in vitamin K, and we want to check their clotting factors and their clotting ability, right? Because vitamin K is used in the process of producing certain clotting factors, 2, 7, 9, and 10. So we can check coagulation if we think someone is vitamin K deficient. And also in the assessment of liver failure. So a patient in liver failure isn't making clotting factors, and we can see the severity of their coagulation defect by checking their INR. Okay, PTT used for heparin, right? We monitor it, and we can adjust the IV heparin dose based on what the PTT is. We can also use actually a PTT to see if someone who's in liver failure isn't coagulating very well, because it's also going to affect their PTT, right? So both PTT or INR and, both INR and PTT, well, if someone's actively bleeding and it's just not stopping, well, we can check their coagulation ability by doing a PT and a PTT, or an INR and a PTT. Okay, so or someone who's having bruising all over the place and we just don't know what the cause is. Well, we could check their platelets, and we can check their INR and their PTT. Okay, so they're used as a test to see how the coagulation system is working overall. And individually, INR is used for warfarin monitoring, and PTT is used for heparin monitoring. Okay, so let's just briefly talk about some platelet issues. So the term thrombocytopenia refers to a platelet count less than 150,000. And there's many things that can cause your platelets to reduce in number. Medications can do it, such as chemotherapy. In actual fact, heparin, one of the main adverse effects of heparin is it can drop your platelet count. So anybody who's on IV heparin as an anticoagulant, we monitor their platelets, because one of the serious side effects of heparin is heparin-induced thrombocytopenia. Okay? There's quite a few autoimmune diseases that can destroy your platelets, leading to thrombocytopenia. Bone marrow diseases, such as aplastic anemia and others, can reduce platelet count. Alcoholism. Alcohol directly suppresses the bone marrow cell production. So not only do you get a macrocytic anemia, but alcoholics typically have a low platelet count. And that's why alcoholics are prone to bleeding. They have a low platelet count, their liver is being injured, so they're not making as many clotting factors. So not only are their platelets diminished, but their coagulation ability is reduced. Okay, so what typical symptoms occur if you just have an isolated thrombocytopenia? It's usually more superficial tissues, so bleeding gums is a common symptom. Um, Epistaxis, so a nosebleed, petechiae on the skin, but you can definitely develop a gastrointestinal bleed as well if your platelets are diminished. Platelet dysfunction is referring to the fact that there's drugs or conditions where you have a normal platelet count, but they just don't work well. So NSAIDs and aspirin are platelet inhibitors, but they don't reduce the platelet count number. Okay? Liver failure or renal failure, where waste and toxins aren't being cleared, they're going to affect the ability for platelets to function normally, even though their numbers might be normal. Okay? Thrombocytosis is an elevated platelet count, and it's not very common, but a platelet count of over 750,000. So this can occur in certain leukemias. It can occur in patients with their spleen removed, but we're thinking of some kind of bone marrow cancer, such as leukemia, if the platelets are really, really elevated. Okay? And when you have very elevated platelet counts, that can thicken the blood and lead to DVTs or PEs because of the excessive numbers of platelets in the bloodstream. Okay, so let's just briefly talk about hemophilia A and hemophilia B. It's a good example of absence of certain clotting factors. So they're both inherited as X-linked conditions. So it's a sex-linked inherited condition, and the condition leads to an absence of a clotting factor. So hemophilia A, which is typically more serious, is deficiency of factor 8. Hemophilia B is a deficiency of factor 9. And males are definitely more affected by hemophilia since it's X-linked. So a mother that's a carrier for hemophilia can give the abnormal X chromosome to their son, and of course they get a Y chromosome from their father. Okay? In the carrier state, it's not an issue. So for, say, a daughter, the daughter might have one abnormal allele for hemophilia, but the other X chromosome is normal, so they don't show the coagulation defect of this disease, such as in a male. And what are the symptoms of hemophilia? Prolonged bleeding, uncontrolled bleeding, gastrointestinal bleeds, huge bruises, and they can actually bleed into joints, right? So they can have what's called hemarthrosis, which is massive bleeding into joints, such as your knee, your hip, or anywhere else, because they're so prone to bleeding. Okay? Patients with hemophilia have to be extremely careful. Minor injuries, especially minor head injuries, can lead to bleeding within the brain. So a patient that presents with hemophilia and has had an injury, we're pretty careful checking that they haven't had a significant bleeding event occur from the injury. Hemophilia is treated with factor replacement. So factor 8 replacement for hemophilia A and factor 9 replacement for hemophilia B. And these are recombinant factor replacements. They can be synthesized. They can be synthesized now. Okay. Okay, I'm not going to go through this. This was done in genetics. It's just showing you an example of X-linked hemophilia and why the son is typically affected with the disease, and the daughter is typically a carrier of the hemophilia gene. Okay, another condition called von Willebrand's disease. So this is actually a platelet issue. Platelets require a protein called von Willebrand's protein in order for them to stick together and form a platelet plug. And this particular condition affects about 1% of the US population. So it's not insignificant. How is it inherited? Well, it's an autosomal dominant disease, right? Which leads to absence of von Willebrand factor. And typically, because it's a platelet adherence problem, it's a difficulty forming a platelet plug. Patients typically present with nosebleeds, heavy periods, a lot of bleeding after dental procedures. Okay, it doesn't affect the coagulation system. It affects the platelet adhesion, and the platelet count would still be normal. How is this treated? Well, this is kind of interesting. We use synthetic ADH. That doesn't make a lot of sense. We use antidiuretic hormone called desmopressin, and this particular hormone actually increases von Willebrand factor in the bloodstream, and it elevates it enough that it helps the platelets form a platelet plug. Okay. I don't think there's too much more to say on that, but I think it's something to remember that desmopressin, which we would think of as reabsorbing fluid in the kidneys, is also used to increase von Willebrand's factor in von Willebrand's disease. Okay, so this is just a summary of hemophilia A and hemophilia B in terms of being X-linked, which factor is missing, whether it's factor 8 in hemophilia A, hemophilia B is factor 9. It's typically not superficial bleeding such as a nosebleed or bruising on the skin. It's often deeper bleeds into muscles and into joints. Okay? What's affected when we test? The PTT is prolonged. The bleeding time is normal because it's not a platelet problem. Von Willebrand's disease, it's inherited as an autosomal dominant condition, so typically you'll know that you have it because your mother or your father had it. Okay, and it's a deficiency of von Willebrand's factor. Now, sometimes in this condition, as part of the inheritance, you can have a slightly lower factor 8 as well. Okay, and that'll come into play when we're just explaining the rest of this slide. So where is the bleeding typically? It's usually superficial because it's the platelets that are affected. And they kind of help all the little tiny bleeds all over the place, like in your skin and in your mouth. Okay, so you'll see that mucous membranes such as a bleeding nose, bleeding gums, bruising, petechiae in the skin, that's what's going to happen. The prothrombin time is normal. The PTT time can be a bit elevated because I mentioned sometimes factor 8 is reduced in this genetic disease as well. Okay, the bleeding time is elevated because the platelets don't adhere properly to each other. The platelets can aggregate, they can come to the area, no problem, but they can't form a platelet plug properly, and that's why you get a prolonged bleeding time. Okay, we're almost at the end. I know I've gone over by an hour. I don't know how I can possibly do 88 slides in 2 to 2.5 hours, so this one's a bit longer. Hopefully you get a lot of information from it. So on the left is bruising from a fall while you're on an anticoagulant, right? So typically that's going to be something like warfarin that's going to do that. It's not going to be aspirin. Okay, so that's all soft tissue bruising. The other image on the right is showing you hemarthrosis. So patients with hemophilia that are missing factor 8 or factor 9, they bleed into joints. And that's why they need regular injections of clotting factor to prevent spontaneous bleeding all over the body. Okay, so hemophiliacs get regular injections of clotting factor to at least get them to a level where they're not actively bleeding into tissues. Okay, let's do a question. We're basically done here. A 67-year-old patient has been diagnosed with aplastic anemia. Which assessment finding is most likely due to the patient's low platelet count? Multiple bruises, pale skin, pulse rate less than 60, cool extremities. Okay, so it's going to be multiple bruises, right, in the skin. Pale skin color is going to be anemia, nothing to do with the platelet count. A pulse rate less than 60, again, has nothing to do with the platelet count. Cool extremities, that could be due from anemia, that could be due from hypotension, but certainly nothing to do with a low platelet count. So it's multiple bruises. Okay, that's it for this module. I really hope you get a lot of information out of it, and try and bring some of it together. And if some of it doesn't make any sense, or if you have questions, write them down, bring them to tutorials, bring them to a question period. Don't leave things unanswered, because then what happens is it just multiplies as you leave more and more things unanswered. Okay, so I hope the module voiceover really helped you. See you at the next module.